Dear colleagues, dear moderator, thank you for having me here. I will speak about how when we incorporated the 3D visualization in our practice, improved, or at least we think that we improved our workflow and outcomes. So we need to think when we need to let go, or if we need to let go the analog microscope and transition to the digital one, what we are actually evaluating. If we compare the classic color image of the analog microscope and the color image with the digital systems, frankly, there is not much of a difference. But when we develop these digital systems, we might develop new opportunities. So what I would say is actually to try to see the new opportunities and how they will change or reshape our surgery and our approach. For example, we might have tissue autofluorescence, infrared imaging, fundus enhancement, contrast enhancement in different structures, even intraoperative fluorescein angiography, which is already a functional data. So it's something else than an image. Of course, ILM enhancement techniques and fluoroscopic vitrectomy. Less known fact is that on the point of ergonomics, the depth of field of analog optical systems is directly related to the presbyopia, meaning to the accommodation of the surgeon. Less accommodation, less depth of field. So when you are in the operating room and you hear the microscope buzzing up and down, you might assume that the surgeon is presbyopic. So what is really important is that all the digital systems which are screen-based, which means far vision, are independent in terms of depth of field from our accommodation. So for a surgeon in a presbyopic age, it's really important. Another thing which is recently seen is that if you're a surgeon and you need to undergo a cataract surgery, normally this is a tipping point for you. Would I see the same through the microscope after my cataract surgery? Or what type of implant I should choose in order to see the same way before my cataract surgery? With digital systems, you see the same because this is a far vision. So this is really important thing to be noted. In terms of ergonomics, of course, neck and back related fatigue can be avoided with the screen-based systems. I don't know how is the feeling with the head-mounted displays, which albeit they try to make them less heavier, they are still on our head. Of course, surgical life expectancy extension, because if we are in better shape and if we can see like we saw before the presbyopia or cataract formation, we will probably work longer and more effectively. So this is a difficult situation in a patient with Bechterew disease where we need to posture the patient. It doesn't really matter how we're going to tilt the microscope. It will not affect our routine position. So it's a regular procedure for me. Otherwise, I need to operate standing up, inclining to the oculars, which is difficult to maintain for 10 minutes and also dangerous because if I can slip or something like that during my hands are in the eye, it will definitely cause a damage. So effects. The most important effect is actually the staff is engaged. Even the anesthesiologists, you know, they are constantly on their phones, so everybody knows on which step of the surgery we are, and if we need any assistance, they can immediately assist us. The workflow, it might be independent from the position of the microscope if the surgeon is sitting on 12 o'clock. I do agree that if the surgeon is temporarily sitting, you need to make some arrangements because of the screen moving in the operating theater, and you might line left eyes first, later on right eyes, in order to improve your workflow. the impact of the high resolution and depth field on the efficiency, we need to untether ourselves from the classic color image. We need to perceive the tissues in terms of details. If certain color is changed and it will increase the color separation and the tissue details, I will accept that image because it will give me more details and I will be more precise. We might visualize the invisible. This is the case with the fluoroscopic vitrectomy because the vitreous is transparent. Also, functional imaging, the fluorescein angio, and intraoperative navigation in the real meaning of that, because we might do a selective endolaser guided under fluoroscopic view. So this should be an example. Yeah, this is an image of the real-time intraoperative fluorescein angiography in case with branch retinal artery occlusion. And you can see now how we can identify the areas of ischemia and treat them selectively. So we don't really induce a damage to all the retina where we don't know if there is a perfusion or no. And this is another case where the vessels seem to be perfused, but you can see the venous stasis, you can see an embolus passing, and later on, after indentation, you will see the reperfusion of a vessel. These are things which are not normally seen or looked for during a surgery. With the intraoperative fluorescein angio, actually, we start to see a new phenomenon which might lead to our treatment approach changes. This is fluoroscopic vitrectomy, where the vitreous is stained with solution of fluorescein. It's absolutely indispensable in the periphery because it stains the stroma of the vitreous, not only the surface, as all the other dyes that we have. And with the fluoroscopic excitation, we might see pretty well what we are doing. We might visualize all the effects of removing the vitreous and the pulling on the retina. This is another example of how we can enhance the ILM staining. We can play with the blue channels, we can play with other channels. It depends from the reflectivity of the fundus actually, and we might develop different filters for ILM enhancement. As you see in this case, this is the same eye, but with different filters. So you can choose because everybody has his own color preference. So it's a matter of imagination, actually. And I'm not sure, yes. Last but not least, it is important and indispensable tool for teaching because the students or the residents are seeing exactly 100% the same image as the surgeon. Also, it's a large screen. It's not a small field of view from the analog microscope. We can record, we can live stream, we can do live surgery, we can do remote mentoring. In this current status of our social networking, it becomes professional networking, and it's the perfect way that we can share what we are doing. Here it is an example of a setting where we can have a remote observation or mentoring with a 3D digital system and VR glasses. Thank you.